One sec.
Recording in progress.
Is my screen visible?
Yes, ma'am.
Okay. Hello, everybody. I'm Dr. Meenakshi, one of the mentors at StudyMEDIC, and today's topic is going to be cellular adaptation to injury, and it's a very important topic where questions can be covered in the exam for part 1. So let us see what are we going to cover today. So we'll be seeing just a brief about what is a cellular injury and what are the cellular adaptations, and we'll look at few examples of both the physiological as well as the pathological cellular adaptations. So what is a cell injury? A cell injury is defined as a variety of stresses a cell encounters as a result of changes in its internal environment and an external environment. So whenever there is any stimulus and whenever there is any kind of injury, the response from the side of the cell could be that either there could be adaptation, or they could be a reversible injury, or they can be an irreversible injury. So how it depends mainly upon the type as well as the severity of the stimulus, and it also depends upon the adaptability of the cell, and overall it depends upon whatever the intracellular phenomenon is there. It mainly depends upon how it's going to respond. But today's topic is only limited to the cellular adaptations. So we can see that whenever there is a normal cell, and if you see that there is some amount of stress, okay, and whenever there is an alteration of the functional demand, that is when the cellular adaptations occur. So they can be in the form of 5 different modes of adaptation, like atrophy, hypertrophy, hyperplasia, metaplasia, and dysplasia. And once the stress factor has been removed, then the normalcy of the cell would be restored. And then we have got the reversible injury. So whenever the cellular ischemia and the hypoxia, when it is only for a shorter duration of the time, then that will be resulting in a reversible cellular injury. Like there will be some degenerations or subcellular alterations and intracellular accumulations. And once it is removed, then the cell would be showing the repair as well as the healing would start. And whenever the stress is very severe, and if it's persistent, that would be resulting in irreversible cell injury, that is the cellular death. So for today, the topic is going to be only related to these cellular adaptations. Okay. So let's see the different kinds of irreversible injury, and they can be irreversible cellular injury, which is nothing but the cellular death, and we've got a programmed cell death, which is called as the apoptosis, and also there could be some residual effects of the cellular injury in the form of subcellular alterations and deranged cellular metabolism, which is shown in the form of like intracellular accumulation of lipids, proteins, and carbohydrates, and after effects of necrosis could be pathological calcification and also gangrene. So coming to today's topic, that is about cellular adaptations, we will be discussing about the different adaptations, that is the atrophy, the hypertrophy and hyperplasia, metaplasia and dysplasia. Usually the hypertrophy and hyperplasia, they usually go hand in hand. So these are the different kinds of the cellular adaptations. So as you can see here, the first one we can see is the atrophy. So we can see in terms of the atrophy that the number of the cells as well as the size of the cell, everything is found to be reduced. And then you can see the hypertrophy. In the hypertrophy, you can see that the cellular size is found to be increased. And coming to the hyperplasia, you can see that the number of cells are found to be increased. And then you have got metaplasia as well as dysplasia. There are certain cellular changes which will be occurring in this. What are those? We will be discussing in detail. So first is the atrophy. Whenever there is a reduction in the number as well as the size of the parenchymal cells of any organ or its part, which was once normal, that we call as atrophy. So this atrophy could be either physiological or pathological. Today, in all the 5 cellular adaptations, we're going to be seeing the examples related to physiological responses as well as the pathological injury. So coming to the physiological atrophy. This is something that we can see, like for example, in case of a menopausal woman, the ovarian atrophy occurs. and also with aging, there would be brain atrophy. And coming to the pathological atrophy, there are different categories, like starvation atrophy that can be seen like cachexia, that is emaciation and generalized weakness, anemia. All of these would come under the starvation atrophy, that is the cachexia, the overall cachexic build. And then we have got the ischemic atrophy. Whenever there is any kind of pathology, let's say cerebral atherosclerosis, there could be like brain atrophy. And also whenever there is renal artery atherosclerosis, they could be resulting in the atrophic kidney. So disuse atrophy is muscle wasting. That is, whenever you see that the limb is being immobilized in a cast, then there would be muscle wasting. And then neuropathic atrophy that can be seen in motor neuron disease as well as poliomyelitis. Endocrine atrophy, which can be seen like in hypothyroidism, hypopituitarism. And also we have got the pressure atrophy. So in pressure atrophy, it is the erosion of the spine which occurs by the tumor in the nerve root, and idiopathic can be the myopathies. So what is the cross morphology that is seen in atrophy is that we see that overall we see both the number as well as the size of the cells is found to be reduced. So because of which the organ appears to be small and it is often shrunken, but they are not dead cells. Okay, and this shrinkage of the cell size is mainly because of the reduction in the cell organelles. Importantly, the mitochondria, the myofilaments, as well as the endoplasmic reticulum. And there is often an increase in the number of autophagic vacuoles containing cellular debris. And these autophagic vacuoles would persist in the form of residual bodies. Like, for example, whenever there is brown atrophy, we can see the lipofuscin pigment granules. The second part is the hypertrophy. So in the hypertrophy, there is an increase in the size of the cells, but not the number of the cells. So because of the increase in the size, that would be causing the enlargement of the organ as well as the tissue. As we've previously discussed, it can be physiological as well as pathological. So in both of these cases, it can be either because of a functional demand or it can be because of any kind of hormonal stimulation. So usually, as I told, the hypertrophy and hyperplasia, they would be coexistent. But if the hypertrophy is occurring alone, usually that does not be affecting, most importantly, the muscles. Mainly the muscles would be affected. And even in terms of like non-dividing cells, only the hypertrophy occurs, hyperplasia doesn't. So the physiological hypertrophy, most important example is a gravid uterus. And pathological, we can see the cardiac muscle atrophy. As I've told you that whenever it is present isolated, most importantly, mainly the tissue that is being affected is the muscles. So we can see the cardiac muscle, whenever there is any kind of mitral stenosis or when there is aortic valvular disease, we can see that there is a left ventricular hypertrophy. And smooth muscle hypertrophy that can be seen in achalasia cardia, pyloric stenosis, and muscular atrophies in hypertension. Skeletal muscle hypertrophy, which you can see in athletes, and compensatory hypertrophy. That means whenever there is a nephrectomy on one side, a unilateral nephrectomy, if you do it in a young patient, we see that there will be compensatory hypertrophy as well as hyperplasia that occurs in the nephrons of the opposite kidney. And adrenal hyperplasia following the removal of one adrenal gland. So as you can see, this is one of the histopathology which is showing the cardiac hypertrophy. You can see that the myocardial muscle fibers, they're found to be thick, and there is abundance of eosinophilic cytoplasm, and the nuclei is also found to be enlarged. So as you can see this, the cytoplasm is found to be eosinophilic, plus you can also see that the nuclear morphology of the nucleus is also found to be altered, and it is increased in size, plus it is also having some kind of the irregular outline. So this is the hypertrophic cardiac muscle fibers. So we see that the affected organ that becomes bulky and it is enlarged and it is heavy. Let's see, like normally we see that average normal heart would be weighing around 350 grams. But when you see that because of systemic hypertension, a hypertrophied heart that can weigh even up to 700 to 800 grams. And you see that not only the muscle fibers are increased in size, but you can also see certain nuclear changes which is found to occur. And at the ultrastructure level, that is what we see, that there is an increase in the synthesis of the DNA as well as RNA, an increase in the protein synthesis, plus also increase in the number of organelles like mitochondria, endoplasmic reticulum, as well as the myofibrils. So this is about the morphology of the hypertrophy, not just the increase in the muscular fibers or not just the eosinophilic cytoplasm. The nuclear morphology is found to be altered because there is an increase in the DNA and the RNA synthesis and also the protein synthesis, plus at the same time, there is changes which occurs at the level of the organelles as well. Next one is the hyperplasia. So in the hyperplasia, we can see that it is the increase in the number of the parenchymal cells resulting in the enlargement of organ or the tissue. Quite often, they can occur together. And all the body cells, they do not have the potential for the hyperplastic growth. Just as I've discussed that in the non-dividing cells, it is usually the hypertrophy. Okay, like neurons, cardiac cells, or the skeletal muscles, because they have got little capacity or no capacity to regenerate. So in this, we see that there will be an increase in the size only. Okay, so all of the non-dividing cells, they will be usually showing the hypertrophy. And then whenever there is any kind of stimulus, it is actually here how the number increases is because there is a recruitment of the cell that occurs at the G0 phase of the cell cycle to undergo the mitosis. So this is the underlying mechanism. So the physiological hyperplasia, which we can see is under the influence of hormones like the increase in the size of the breast, which occurs in puberty as well as during the pregnancy, the benign prostatic hyperplasia, and also the endometrium during the proliferative phase. We can see the compensatory hyperplasia, which occurs like in case of liver regeneration or the epidermis regeneration when it occurs after the skin abrasion. These are a few examples of the physiological hyperplasia. Coming to the pathological hyperplasia, whenever there is any kind of increased estrogen, like unopposed estrogen, when it is given, that would be causing an endometrial hyperplasia. So that is pathological. And you can see because of the HPV virus, whenever there is a skin warts that you can see, that is mainly the hyperplasia of the epidermis, which is occurring, and also the intraductal epithelial hyperplasia, which occurs in the breast in the fibrocystic breast disease. And coming to like the mechanism, what happens is there is an increase in the DNA synthesis causing an increase in the number of the mitosis, and that would be causing the enlargement of the affected organ. And the next one is about the metaplasia. As you can see, metaplasia is nothing but that is the reversible change of one type of epithelial or the mesenchymal cells that would be changing into another type of the epithelial or the mesenchymal cells that occurs usually in response to the abnormal stimulus. And once you remove the stimulus, usually that would be coming back to normal. But you see that in case the stimulus is persistent for a longer period of time, then there is a possibility that it might turn into a cancer. So we see that it is known to be affecting both the epithelial tissues as well as the mesenchymal tissues. Let's see a couple of examples. See, in the epithelial metaplasia, as compared to that of mesenchymal, this is found to be more common. And among the epithelial metaplasia, the squamous metaplasia is found to be more common as compared to that of the columnar metaplasia. So whenever we say columnar metaplasia, that means a particular epithelium is getting transformed into the columnar type. Let's say, for example, in Barrett's esophagus. And when it's a squamous metaplasia, it means that a particular epithelium is getting transformed into the squamous type. So whatever is the prefix to the metaplasia, that means that the epithelium is getting changed into that. So as I've told, epithelial is more common than mesenchymal, and among the epithelial, the squamous is found to be more common. Okay. So we can see that there are different types. So this the squamous metaplasia, it happens, whenever there is like wide variety of like irritants, which could be like mechanical, they could be chemical irritants, or they can be infective irritants. Like for example, it can be seen in bronchus. So normally the bronchus is lined by the pseudostratified columnar epithelium. So that is getting changed into squamous. And then you can see the endocervix normally it is lined with the simple columnar epithelium. Then the renal pelvis normally it's having the transitional epithelium. So all of these are getting transformed into the squamous epithelium type because of some kind of trigger. And then in the columnar epithelial, columnar metaplasia, you can see that there is an intestinal metaplasia in healed chronic gastric ulcer. And as we have discussed regarding the Barrett's esophagus, where the squamous is becoming into columnar epithelium, and also the cervical erosion. Okay, there is a variable area of endocervical glandular mucosa, which gets everted into the vagina. That is nothing but this is also one of the types of the columnar metaplasia. So coming to the mesenchymal metaplasia, in this we've got two different types, the osseous as well as the cartilaginous. In the osseous metaplasia, it is the formation of the bone in the fibrous tissue or in the cartilage as well as the myxoid tissue. So certain examples are like, in the arterial wall in case of the old age, which is called as a Monckeberg's medial calcific sclerosis, and also in soft tissues in myositis ossificans. And in elderly people, we can see in the cartilage of the larynx as well as the bronchi. And whenever the scar of the chronic inflammation of prolonged duration, as well as even in the fibrous stroma of the tumor. Coming to the cartilaginous metaplasia, we can see it like in the terms of like healing of the fractures. When you see that there is undue mobility, in such cases, we can see the cartilaginous metaplasia. But as compared to mesenchymal metaplasia, the epithelial is more common, and in epithelial, the squamous is more common. So as you can see, this is a classic example of the columnar metaplasia, which is the Barrett's esophagus. So we can see that the esophagus, it is normally lined by the squamous mucosa, right? And because of the triggers, what happens is there will be a metaplasia that is getting converted into this columnar epithelium. Okay, so this is a classic example of columnar of the columnar metaplasia, extremely important. And then would be the final topic of today, which is going to be the dysplasia. So dysplasia itself means that, there is a disordered cellular development. The dysplasia would most often occur in the epithelial cells, and this epithelial dysplasia is characterized by different kind of cytological changes as well as the cellular proliferation. As we have discussed in the in the first few slides, when I've shown a diagram where there is like branching, when, what happens to hyperplasia, what happens to hypertrophy, and what happens to dysplasia. I told that we'll be discussing further. So this slide is actually showing a few changes that is known to occur in case of a dysplasia. Like, what are the cytological changes? The changes which occurs at the cellular level. We see that, there will be an increase in the number of the layers, that is stratification of the epithelial cells. And also there could be a disorder arrangement of the cells, starting from basal layer to surface layer. Dysplasia, disorder arrangement. Okay, the basal polarity would be lost, and there is a cellular and nuclear pleomorphism, plus there is an increase in the nuclear cytoplasmic ratio, and there is nuclear hyperchromatism, and also increase in the mitotic activity. Okay, so these are a few changes that are known to occur in dysplasia. So as you can see, this is also like one of the examples where, we can see that this is actually a normal endocervical epithelium when it is actually undergoing the squamous metaplasia, and then this actually the dysplasia, which you can see that there is a disease, disordered orientation, loss of the polarity, and starting from basal layer to the superficial layer, we can see that it is disorderly arranged. Okay, and increase in the stratification, all of these. And if you see like at ultramicroscopic level, we can also see that there will be an increase in the nuclear cytoplasmic ratio. All of these features are found to be the examples of the are said to be the features of the dysplasia. And this is the uterine cervical dysplasia. As you can see, the high-grade lesion. So you can see that, there is an increase in the number of the layers. Okay. And as you can see that there is an increase in the layers. And here you can see that these are the mitotic figures which are seen in the cells. Okay. And this is the disordered arrangement that we can see of the squamous epithelium. Okay. So this is the table which is showing the comparison between the metaplasia as well as the dysplasia. So in the metaplasia, we see that, there is a change from one adult epithelial or the mesenchymal type to another epithelial or the mesenchymal cell. Whereas the dysplasia, it is something where there is a disordered cellular development which can be accompanied along with the metaplasia or with the hyperplasia. Coming to the types, as we've seen that in metaplasia, we have got epithelial type and the mesenchymal type. In the epithelial, we've got squamous and columnar, and in the mesenchymal, we've got the osseous as well as the cartilaginous. And then we've got the dysplasia. In the dysplasia, it is known to affect only the epithelium. And coming to the tissues which are affected, in the metaplasia, we can see the bronchial mucosa as well as the uterine endocervix and the renal pelvis. These are like few examples where we can see metaplasia. And the dysplasia, we can see that it is seen in uterine cervix as well as in the bronchial mucosa. And coming to the cellular changes, there is a mature cellular development in the metaplasia, whereas in dysplasia, you see that there is a disordered cellular development. And as we've just discussed, that there is an nuclear cytoplasmic ratio would be altered, and there could be an increase in the hyperchromatism plus loss of basal polarity. Okay, all of these are features of dysplasia. Whereas in metaplasia, it is not like that. There is a mature cellular development, and metaplasia is reversible on the withdrawal of the stimulus. But if the stimulus is persistent, then it would also, there is a possibility that it could turn into a cancer. Whereas in dysplasia, once the triggering stimulus has been removed, then definitely it would regress. But in case of persistent, there is a chance that it would be developing into a carcinoma in situ. So this is a tabular representation of the differences in the metaplasia and dysplasia. So that comes to the end of the session, and I hope it was clear and it was informative. In case of you have any kind of doubts, please to put it in the comments down below. And if you have any suggestions, that also can be put in the comments down below and we shall take it. And do not forget to subscribe to our channel. I will see you all in another one. Until then, happy studying. Bye.
Recording stopped.
Are we done?